Still on Rcgp case cards. This particular one says, explain nerve conduction testing to a patient with typical features of ulnar nerve compression. So recently I actually saw a patient with ulnar nerve compression, confirmed on nerve conduction study. So it's not too common, it's not very common, but you would come across it. The weakness and numbness in your arm and hand suggest a problem with the ulnar nerve. You know when you knock your funny bone and get the odd shooting pain down your arm? That nerve is your ulnar nerve. It controls certain hand movements and allow you feel the side of your hand. The ulnar nerve is long, running from the spinal cord in your upper back, past your shoulder, wrapping around your elbow, then all the way down to the palm of your hand. Your nerve may have been damaged or compressed at any point along these routes. I would like to send you a test. I would like to send you for a test to try and locate the site of damage. The test involves placing small electrode stickers along the roots of the nerve and sending impulses along it, which are then picked up by a machine. The electrical impulses can feel pretty uncomfortable and can cause your hand muscles to twitch, which feels quite strange. As soon as the test is over, your arm will feel back to normal and it will not cause any damage. We will get a report a week or two later, which should confirm the problem and tell us if the nerve is damaged at the elbow, shoulder, or elsewhere. We may need to refer you to a surgeon to release the trapped nerve once we know where the problem lies. So the patient I recently saw, I had to refer her to the orthopedic team to consider a decompression of the ulnar nerve or an ulnar nerve repositioning. So sometimes they may need to bring the ulnar nerve to the front of the medial epicondyle, so ulnar nerve repositioning, or sometimes you might just need to, the decompression, maybe to widen the ulnar, what's it called now, the ulnar groove behind the medial epicondyle. Okay, you might need to maybe widen it if it's too narrow and compressing on the nerve, or just decompress whatever it is that is pressing or impinging on the nerve. So the next case card, Rcgp case card, says, discuss the diagnosis of depression with a stressed and tearful 37-year-old woman who has a PHQ-9 score of 19 and outline her treatment options. I can't even remember the last time I used this PHQ-9 patient health questionnaire 9. Most times in depression assessment, I really don't use it. I interact with the patient and ask specific questions. You can actually know if a patient is depressed or not. Let's go ahead. Your symptoms and your questionnaire suggest you're suffering from depression. It might surprise you to know that 2 out of 3 people suffer with depression at some point in their lives. Sometimes it's triggered by stressful events, like a relationship breakup or money worries, but it can just come out of the blues. There are a number of ways that I can help, and different options suit different people. Some people want to try self-help resources like the internet and books. Others prefer talking to someone like a counselor or a different type of therapist. Talking to a stranger isn't everyone's cup of tea, though. Some people prefer to deal with it on their own or with the support of friends and family. We could also try antidepressants. These won't fix all your problems, but they can help you cope with them better. They won't kick in immediately, but most people notice some benefits after 2 weeks. Side effects like nausea, dry mouth, and dizziness tend to occur when you start these tablets. So you may feel worse before you feel better. And that's something that you have to tell you. You may feel worse before you feel better. I would like to see you regularly to see how you're getting on with them. Regardless of what we do, the majority of people will get better. So you need to reassure the patient that most people will actually improve over time in terms of their mood. Of course, you offer them the option, psychological therapy, medications which are antidepressants, and then find out what the patient thinks in terms of what they would like to start with and the options they would actually like to consider. So the third one, it says, talk to a 23-year-old man about suspected first generalized fit, so seizure. From your symptoms, we think you've had a fit. A fit is a short burst of abnormal electrical activity that travels over your brain. About 1 in 20 people have one fit in their lifetime. It's only if you have repeated fits that it becomes epilepsy. The most important thing is to get an accurate story of what happened from someone who saw you fitting. I'm going to refer you to a specialist to try and confirm the diagnosis. And you should try and take that person with you. So take the person who witnessed it with you. The specialist will go over the story in detail. They'll also want to do some tests. These are likely to be a brain scan and a test where they look at the electrical activity in your brain by placing painless, sticky electrodes on your head and attaching you to a machine. They might also want to do some blood tests. You need to know that the tests are not foolproof. However, and some people go on to be diagnosed with epilepsy despite having normal tests. It's very important that you don't drive between now and seeing the consultant. The consultant will then let you know whether he thinks this was a fit or not. If it was a fit, you aren't allowed to drive until you've had a year free of fits. You must tell the DVLA that this is what the consultant recommends. Yeah, so driving, suspected first fits, you have to refer the person to the seizure clinic, okay? To the seizure clinic, where the patient will be fully assessed, detailed history, physical examination, neurological examination, and then, the need for further investigations like a CT scan of the head or MRI scan or an EEG, which is electrical tracing of the brain, will be discussed if needed. The next Rcgp case card says, explain to a 20-year-old the need for an EpiPen following a severe allergic reaction to peanuts. Allergic reactions vary from mild to severe. Mild ones may just cause a rash, but other symptoms include diarrhea, vomiting, swelling, or difficulty breathing. A reaction is severe if it involves swelling of the lips or throat or causes difficulty breathing. In extreme reactions called anaphylaxis, it makes you collapse. Unfortunately, if you are very allergic to something and are exposed to it several times, the reaction can get progressively more severe. For this reason, it's important to avoid peanuts at all costs and to know what to do if a reaction starts. The first thing is to keep as calm as possible and make sure you have help around. It can help to drink some water to clear the back of your throat if you have accidentally eaten a nut. You should take antihistamines like Piriton as soon as you think a reaction may be occurring. If you get throat swelling or feel breathless, use your EpiPen. The adrenaline in the pen opens up your airways and allows you to breathe. It is not a drug to take lightly, and you should always call an ambulance if you've been bad enough to need it. I'm going to give you 2 EpiPens, which you should have with you at all times, as a second dose is sometimes required if there's been no response with the first. And this is the 5th case card for this session. This case card says, explain the diagnosis and initial management of asthma to a 15-year-old boy. This is a teenager. You suspect it's a teenager with symptoms of asthma, so you have to explain this to him. Asthma occurs when the airways in your lungs become inflamed and narrowed. As I'm sure you can imagine, this means you can't get air in and out of your lungs easily, and that's why you've got the tightness, cough, and wheezing when you breathe. The narrowing comes and goes, which is why you don't have the symptoms all the time. Cold air, allergies, and smoking can all set asthma off. Exercise is a bit odd in that it can make your symptoms worse while you are doing it, but in the long term, it can improve your lung function, so don't avoid it. I would like to try you on a blue inhaler called Ventolin or salbutamol. It opens up your airways when they become tight and allows you to breathe more easily. If you are using the blue inhaler more than twice a week, you may need a second regular inhaler to keep your symptoms at bay. We have a nurse in the practice that sees all our asthma patients regularly at least once a year. She will make sure you are on the best possible treatment. You know how to use it, and that your symptoms are well controlled so that the asthma doesn't stop you doing anything you want to do. So the practice nurses usually help in managing asthma and COPD and even diabetes. So you usually want to book the patient to see the practice nurse who will help to optimize the asthma treatment. So the catch here is, if you are using the blue inhaler more than twice a week, you may need a second regular inhaler to keep your symptoms at bay. And that's usually an inhaled corticosteroid. Because in asthma, usually, you don't start the LABAs. You don't start the long-acting beta-2 agonist, right? Without the patient being on an inhaled corticosteroid. I think so. Correct me if I'm wrong. I think it's LABA, not LAMA. It's LABAs, yes. You don't start LABA, so you start with PRN, salbutamol, and the patient is having to use it more than twice a week, you then introduce the inhaled corticosteroid preventers. And if that's not helping, you can always up the dose of your steroid. If that doesn't help, you can always introduce your LABA, okay, like the salmeterol, okay. You can, and then you can always introduce your LAMAs later, like the tiotropium. Should we do one more in this session? Let's do one more. This one says, discuss the risk of cystic fibrosis in this pregnancy. Patient is 6 weeks pregnant with a couple who already have a child affected. And the child that is affected is named Tilly, and Tilly's age 2 years old. I gather you are 6 weeks pregnant now. To answer your questions about how likely this baby is to be affected, let me explain how the genes work. Genes are the body's way of passing on memory codes for the cells in the body. When a baby is conceived, it receives a set of genes from each parent. Faulty genes can be passed on too, but with some genetic conditions, the illness is only present if the baby gets 2 faulty genes, 2 faulty copies passed on. Cystic fibrosis is one of these conditions. Because both you and your husband have one normal and one cystic fibrosis gene, there are 4 possible combinations of genes the baby can receive. Let me draw this for you. The chance of your baby getting both faulty genes and therefore having cystic fibrosis is 1 in 4. So it's usually good to do. I always do the Mendelian cross match, whenever I'm discussing autosomal recessive, autosomal dominant, or sex-linked recessive. I always do the Mendelian cross match, just so I'm sure of exactly what I'm saying. This means there is a 3 in 4 chance that your baby won't have cystic fibrosis. As you can see from my diagram, half of any offspring you have will be carriers of the faulty gene. Well, for every pregnancy, there is a 2/4 chance of the baby being a carrier. A 1/4 chance of the baby having cystic fibrosis, and a 1/4 chance of the baby not having the abnormal gene, not being a carrier and not being affected. We can test for cystic fibrosis at birth, but some people want to know during the pregnancy. Chorionic villus sampling, or CVS for short, can be done from 10 to 13 weeks. Or another test called amniocentesis at about 20 weeks. Both these tests can confirm the condition, but like most tests, they are not 100% accurate. They also carry around a 1% risk of triggering miscarriage, as they involve inserting a needle into the womb. So it's something you need to tell the patients. There's a risk of miscarriage, 1% risk of miscarriage from both chorionic villus sampling and amniocentesis, because a needle is inserted into the womb. And it's good to know that chorionic villus sampling is usually done at 13 to 14 weeks, so towards the end of first trimester, beginning of second trimester, whereas amniocentesis is usually done at 20 weeks gestation. So this is quite an important, in fact, I'll keep this case card separate because it's something I want to go through again. Genetics. It's really good to know how to explain genetics to your patients, because it actually happens. You encounter it in your practice in primary care. Cheers, guys.